Please welcome to the stage President and CEO of the Congressional Black Caucus Foundation, Nicole Austin-Hillery.
Good morning. I am Nicole Austin-Hillery, President and CEO of the Congressional Black Caucus Foundation, and I am so excited to welcome you here this morning to our 2025 Policy for the People Health Equity Summit. You know, we are just steps away from the nation's capital, and we're here not simply to have a discussion on policy, but to shape it. You all have the power to be change makers right where you sit. I'm so honored that we are represented in the room and joined by so many policy advocates, community leaders, experts, and scholars. You all truly have the power to create the pathway for change that we know is so crucial and needed in our communities. This year's focus for our summit is access and affordability in chronic disease management and prevention. And we know this issue speaks to the dire need that we have to dismantle the structural inequities that exist in our communities. Now, as I said already, this room is filled with so many powerful people, and we are proud that you all are not just standing with us, but standing by us. And as always, we are so pleased to have members of Congress here, the members of the Congressional Black Caucus, who are unwavering allies in our fight for justice, equity, and to ensure that we have health outcomes that are beneficial for all. Now, make no mistake about it, this is not just another summit. My team hears me say this all the time. I love that you all look beautiful and pretty, and you do, and you smell good too. But we are here to get work done. We have serious issues in our nation, in our communities around health equity, and we have serious disparities. We need to close these gaps, and it is going to require all of us, our intelligence, our tenacity, and our commitment. So we are here today to problem solve and to walk out of these rooms with answers and strategies that we can put into effect immediately. Now, each year, our Policy for the People gives us a platform to listen, to learn, and to lead. And this year, we turn our focus again to an issue that we know is urgent and deeply personal for so many of us. I know for many of you that I've been talking to this morning, these issues hit close to home. They hit close to home for me as well. And our communities need help and they need answers right now. Diseases like cancer, heart attacks, diabetes, they don't just threaten lives, they expose structural cracks in our systems around healthcare in this country. And too often, these systems do not serve our communities well. And in fact, they rob people of opportunities and they rob them from the full lives that they can be engaged in and have. So health equity begins with something very simple, and that's access and affordability. These are not simply options for good health care, they are essential. Now, our communities, again, we know carry an unequal burden when it comes to health. They face things like delayed diagnoses, limited access to affordable care, rising treatment costs, and a legacy of medical neglect that has eroded trust in our systems in this country around healthcare, the very systems that we are supposed to trust and that we look to heal us. So these are not just health challenges, these are justice and equity challenges for all of us. So that's why today matters. That's why it's important. That's why all of us coming together and using our collective brain power is going to make a difference. I have the distinct honor and privilege of introducing someone that I know you will be excited to hear from. You will get to hear from her in a little bit in a conversation we're going to have about our policy playbook. But she plays a very important role for us here at the Congressional Black Caucus Foundation. Congresswoman Terri A. Sewell, who represents the 7th Congressional District in Alabama, serves as the chairwoman of the Congressional Black Caucus Foundation. So I invite her to the stage to bring you greetings as we get started with our conversations today. So please join me in welcoming Congresswoman Terri A. Sewell.
Thank you, Nicole, for that gracious introduction and for your tireless leadership in advancing the Congressional Black Caucus Foundation's mission to uplift and empower Black communities. I'm Congresswoman Terri Sewell. I proudly represent Alabama's 7th Congressional District, and I am honored every day to serve as chair of the CBCF Board of Directors. You know, I know how important it is that we deal with all the policy issues that are before the African American community. But today's summit is an opportunity for us to share with you not only expert advice, but to hear and listen to you about what we can all do together to uplift our communities. Today's summit isn't just a policy exercise, it is the reality faced by my district and by Black families nationwide who are navigating illness with limited resources and even fewer options. The facts are undeniable, and they are truly unacceptable. Black Americans are 55% more likely to have high blood pressure, nearly twice as likely to be diagnosed with diabetes, and more likely to die from heart disease and many forms of cancer than their white counterparts. These are not just disparities by chance. They are the result of systemic inequities that have been allowed to persist for generations. That is why today's Policy for the People Health Equity Summit is not just timely, it is an imperative. This year's focus on access and affordability in chronic disease care is about getting to the root of the problem and demanding better. Because access to quality, affordable health care should not be just a privilege for the few. I truly believe, and I'm sure you all too, that in this great country that we live in, healthcare should be a right, not a privilege for the few. The Congressional Black Caucus Board of Directors stands firmly behind this work. We are not just stewards of the foundation, we are strategic partners in its mission to confront health inequities head on. We support the Center of Policy Analysis and Research and its ongoing efforts to produce data, elevate lived experiences, and influence policy that brings real change. And that commitment continues with today's robust agenda. Throughout the summit, you'll hear from leading voices, including public health experts, community activists, and private sector innovators, all of whom are working to shift the health outcomes of our people. Today's breakout sessions will deal with complex realities and urgent needs surrounding chronic illnesses in the Black community. From the rising costs of prescription drugs to the gaps in healthcare workforce to the potential of alternative medicine and cultural competency care, these sessions will spark necessary dialogue. Each was developed in collaboration with the trusted sponsor organizations and the CBCF team. I extend my deepest thanks to our partners for bringing their insight, their leadership, and resources to this critical space. Let me close with this. Health equity is not a talking point. It is a matter of life and death. It is commitment that we must renew daily through policy, through practice, and through partnership. At the CBCF, we don't just envision a future where Black lives are valued and protected. We are building it, piece by piece, policy by policy. So thank you for sharing your day with us. Thank you for believing, as I do, that equity in healthcare is not only possible, it's non-negotiable. Let's begin with a discussion to action. Now it is my honor to introduce a tireless champion for equity and innovation, my colleague and sister in service, the chair of the Congressional Black Caucus Health Brain Trust, none other than Robin Kelly. She will be joining us on our panel. I'll bring Nicole back up. Come on in. She's also not only represents Illinois, but she is a fierce advocate for all things Illinois. And I am happy to be able to announce that she is running for that seat that Dick Durbin just about to give up, and she will be our next senator. We're claiming it. I want to thank Nicole and Dr. Jonathan Cox for your tireless leadership and your work in this space. And let's begin today's summit. Thank you all.
I could not let this morning pass without letting you all hear just one or two words from our Center for Policy Analysis and Research Vice President, Dr. Jonathan Cox, whom you just heard the Congresswoman mention. He and his team have just done amazing work to ensure that the summit could come together, but also around this critical research that's found in the policy playbook. So without further ado, please join me in welcoming my colleague, our Vice President for the Center for Policy Analysis and Research, Dr. Jonathan Cox.
Good. We're going to have some energy today because it's a great day. Sun is shining, and we're talking about health equity for Black people. Y'all should be excited, right? Thank you. Absolutely. So I would definitely like to offer you all my thanks for joining us today for our Policy for the People Health Equity Summit. As was said, my name is Dr. Jonathan Cox, and I am the Vice President for our Center for Policy Analysis and Research. I also want to extend my thanks to, again, just to each of you for taking your time to be here. I also want to say thank you to the CBCF team, just for all of the work that they're doing, to continue to do in efforts of supporting Black people. It's all this dedication that comes from our team. It's a small but mighty team that really makes this work possible. So I just wanted to make sure I recognize them. Now, in the center, oh yeah, thank you. Clap, right? We were just talking about that. So in the Center for Policy Analysis and Research, or CPAR, we're committed to improving the socioeconomic circumstances of Black Americans by providing timely, relevant analyses and policy recommendations that directly address issues that are really important to our communities. And so it gives me great joy to introduce this opening session today, not only because of the dynamic individuals that you will be hearing from, but also, as Nicole was saying earlier, this session focuses on some of the more recent work from the Center for Policy Analysis and Research and the Foundation. And so Nicole told you about our policy agenda that was just released, Forward Together, the Black Policy Playbook for an Equitable America. This was done in partnership with the Joint Center for Political and Economic Studies. Could not say enough thanks to them and their team for the work on this as well. Thank you. And so in creating this policy agenda, the two organizations, we really worked together. We looked at a lot of rigorous research, a lot of evidence-based policy recommendations from various partner organizations. And so this playbook really highlights the importance of policies that are We're going to do things like close the racial wealth gap, that are going to do things like ensure equitable access to education, healthcare, technology, and the workforce for Black people, protect voting rights, and facilitate a fair and just legal system for all. And so we really encourage you to dive deep into this policy agenda, share it far and wide with all of your networks, right? We want to make sure this is getting out so that people can see this information. You can find that information on both our website, the CBCF, as well as the Joint Center's website. If you just go to our home pages, you can see that. And so again, excited to share that. But then I'm also excited because this opening roundtable is going to talk not only about this policy agenda, but another really important body of work that we have been producing this year, which is our executive order tracker. Now, we know that just starting in the first week of the second administration of the current president, right, he released a slew of executive actions and executive orders really to transform the federal landscape, the federal government, and to implement various policy changes. And so our team at CBCF created this executive order tracker as a way to help increase knowledge and understanding of these executive orders and their impacts on Black communities. And so again, really want to make sure that you all are checking this out, take the time to view it. It's an interactive website that you can look at. We have 36 different executive orders that we have been tracking thus far and their particular impacts for Black communities. And then also really uniquely, one of the things that we feature as part of this tracker are words and responses, actions from our own Congressional Black Caucus members, right? We want you all to know that our members are fighting tirelessly for Black people. They have been doing this for decades. They continue to do this work, and we know that all of these executive orders end up being distractions and changes, but we have folks that are on the ground really fighting for you all in our communities. And so we want to make sure that you're checking that out as well. But with that, I want to get out of your way. I want to make sure that we get time for this wonderful opening panel. So how about we get started? And so again, my honor to hand the mic back to our fearless leader and CEO, Nicole Austin-Hillery, for a great opening roundtable. Please join us. Join me in clapping for them.
Thank you, Dr. Cox. And look, we've gotten this started. You've already met our wonderful leaders, but I want to add one more person to this conversation, and that is Dedrick Asante. He is the President and CEO of the Joint Center for Political and Economic Studies. Please join us for this conversation. So I want to start with a big picture question. And everyone, I hope you all have the beautiful playbook in your hands, okay? So we want to focus on this. Again, I love that it's called a playbook. I want to ask each of you, and I'm going to start with you, Representative Sewell. We already know, we've talked about what this playbook does, what it lays out. But can we just lay the groundwork for today's conversation? And I'm going to ask each of you this question. Tell us, what is the state of play right now in this country for health issues for the Black community?
Well, let me first say again how proud I am of the CBCF and the Joint Center for putting together this playbook. When I think about health equity, I have to tell you, it was the reason why I ran for Congress. I represent Alabama's 7th District. It includes the historic cities of Birmingham and Montgomery and my hometown of Selma. But it includes the Black Belt, where access to health care is in dire straits. And I think that if I had to use one word to describe where we are right now, and we're in chaos. This administration has done everything it can to take away the progress that we've made and to take us back. And I sit on the House Ways and Means Committee, and I know that my colleague will talk about her experience on energy and commerce. But we just spent last week marking up his big, beautiful bill, which is more like an ugly nightmare of a bill, last week. 18 hours in Ways and Means. And I can tell you that he's looking to let the Affordable Care Act enhance premium credits expire. And I don't know about you, but I can tell you that in my district, 161,000 people can afford health insurance. Why? Because we gave them a subsidy. We helped to subsidize their health insurance. If we allow that to lapse, which he plans on doing December 31st, 2025, it will kick people off of health insurance. Now, on top of that, they have the nerve to also cut Medicaid by $880 billion. Why? To give a tax break to billionaires and millionaires and the well-connected. It is not only criminal, it is immoral, in my opinion. And we have to speak up and speak out. I know that the Democratic caucus, as well as the Democratic members of Ways and Means and Energy and Commerce, we did fight against it. We proposed amendments that would actually make it a little bit better by eliminating some of the things that are most egregious. But the reality is they passed it. They're going to pass it come Thursday out of the House of Representatives. And it is going to be a shock to our system in an effort to take us backwards and not forwards. And we need to do everything we can to make sure that we hold them accountable for this disastrous policy.
Thank you. Representative Kelly.
I don't know if my colleague left anything for me to say, but but I actually ran for Congress on a gun violence prevention journey, and I consider gun violence prevention a public health crisis. And as soon as he came in, he shut down the Office of Gun Violence Prevention, and they've taken away all kind of grants that were already allocated, already voted on. But I do sit on Energy and Commerce, and we beat them 26 and a half hours. We were in markup, and every amendment that we put forward, they voted no. Even amendments they already agreed to, like I led the legislation where the postpartum coverage for women on Medicaid having a baby goes from 60 days to a year. And it's optional, and to my shock, 49 states agreed to do it. And I was trying to make it permanent, and they agreed to that in December or November, but the other president, Elon Musk, told them no, 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 so it didn't make it. So we brought it back up, and even though they voted on it and made it out of committee, they all voted no this time. And in my district, 300,000 people out of 753,000 people would lose their health care. And what they want to do, food is medicine, and they want to cut $230 billion out of SNAP. In my district, that would affect 190,000 people. But we can't just look at it like that. We have to look at the economics. So that means wherever your folks shop, less people will shop. Less people shop, less farmers will be able to sell their goods. I have 4,500 farms in my district. I'm urban, suburban, and rural. So then, farmers will suffer. Then people will get laid off in the stores. We have to realize that we're all connected. So like Rep. Sewell said, it's chaotic. It's evil and cruel. Also, is it evil and cruel what they're trying to do to the public? And again, we are fighting with every tool in the toolbox, including shaming them to death, because some of them, one of our colleagues, had 62% of his district is on Medicaid, and he voted for this crap. I mean, it makes no sense, but hopefully he'll pay at the ballot box. Thank you.
Thank you. So Dedrick, you spend a lot of time at the Joint Center with your colleagues doing research, looking at these data points. What are you all seeing?
Well, I'll just reiterate, actually, what the Congresswoman was stating, in that you asked, what is the state of health policy? And clearly, they're highlighting the state of health policy right now is really being determined in the budget conversation, in the tax conversation. And I'm glad everyone is here to, talk about health equity, but this requires you to become a policy expert a tax expert on how the tax system is going to fund the health equity programs you need are so important. What is the budget doing as it relates to the health issues you're so concerned about? And so, I think we were all maybe a little overtaken by the blitzkrieg of executive orders that the Congressional Black Caucus Foundation did such a great job on their website of highlighting, of tracking what's happening with the executive orders. But now we're at the space where really long-term change is really made, and that's in policy and budget. And it's time for our voices to be heard. And I'm so excited that Joint Center is able to put out a policy playbook overall that highlights how all of these issues are interconnected.
Thank you for that, Dedrick. And as I was listening to you and Representative Kelly in particular, I was thinking about this morning as I was getting dressed to come here. I heard no fewer than 3 stories on NPR this morning about healthcare and about the problems we are facing. And one of them that I heard about was talking about women and maternal health care. And I know for you, Representative Kelly, that is a particularly poignant area of focus for you and your legislative agenda. And we know that when it comes to Black women, maternal health disparities truly plague our communities. Can you talk to us about what we're facing now in terms of that issue area and what kinds of things we should be looking for as tools to help us protect those interests?
Well, again, black women are 3 times as likely to lose their life than their white counterparts, but that's just an average. Where I represent in the Chicagoland area is higher than that, and there's places it's higher than that. So, and particularly in the South, there's those are the highest states for the most part. And if they cut Medicaid, again, 40% of women that have children, they have Medicaid.
And 55% in the state of Alabama.
Right, that's just an
Medicaid.
average. In some places, you know, excuse my voice, is much higher. So you're talking about, again, taking health care away from women. But the other thing they're doing with all the cuts at NIH and, you know, with HHS, 20,000 people losing their jobs, that affects hotlines that women can call and research that's being done. We will not only suffer, we will die. We will die. I worked with many people in the healthcare field, OBGYNs, doulas, midwives, nurses, to suggest what we should do as far as maternal mortality and morbidity, and they're destroying everything that we've put in place. And you can't keep cutting federal workers and expect the work to be done. And that's in a lot of entities, not just healthcare.
And of course, they're cutting all these grant programs that help with health equity and disparities. For example, $191 million was cut from public health. And I can tell you that in Alabama, the public health grants that we got went to the poorest parts of the state of Alabama. I represent one area, the Black Belt, 9 counties, and where the social determinants of health work against our people. Not only is there lack of transportation and poverty, there's poor housing, poor sanitation. And a lot of those grants that we authorized and we appropriated money for, they're now terminating those grants. How they're doing it, when Congress appropriated, I know it's working its way through the court system, but you and I both know that that is unacceptable, that our colleagues, our Republican colleagues, are literally letting the executive branch take away the power of the legislative branch. Now, I know my senator doesn't know this, but there are 3 co-equal branches of government. My Alabama senator, I thought there was only 2. But at any rate, there are 3 co-equal branches of government, and we've got to, I mean, the fact that they're like literally kowtowing to Elon Musk and to President Trump is really abhorrent. And I think that these grants, anything that has to do, I think that they're going through, DOGE is going through a word search on their computer. If it says diversity, equity, or inclusion, literally, they're flagging all of those grants and they're terminating them. And I am really worried because the only reason and the only way that we've been able to close the gap on such things as diabetes and renal failure in my district is because of the data and because of the resources that we're bringing to bear to close that gap. And 4 years, I don't care if the Supreme Court comes back and tells us they shouldn't have done it. We know they shouldn't have done it. But I'm afraid that it's going to be irreparable harm. And we're going to be going and set back. And I know that all the healthcare professionals that are out in the audience understand and know that we have got to double down on our efforts and in order to make sure that we're
One thing I forgot to say, also all the hospitals that'll close, and I'm already seeing hospitals in my district that have stopped doing maternal care. People have to go to another hospital, but I have hospitals hanging by a thread right now.
My rural ones especially. Yeah.
You know what, Derek? Go ahead. Look, I love this. Look, we're just gonna have a conversation, y'all. Okay? I don't need questions. Derek, what you hear the congresswomen talking about what's happening in their and not just their districts. This is happening all over the country. Derek, what kinds of things should we be looking at? What kind of levers of change should we be looking at? And I know that's what you and your organization and the work that we produced in this playbook, that's what we're talking about. What should folks be looking at in terms of ways that they can try to fight back?
And I just want to clarify, yes, I will identify the levers of change. I just want to identify, though, I think the Congresswoman, mentioned how strategic they've been attacking, our health care. The little progress has been made, or substantive progress has been made in health equity. I'm just thinking 4 or 5 years ago, we went through the world went through one of the greatest healthcare crises that the world's experienced, definitely in my lifetime. I know between me and my wife, we lost 7 members of our family in that first year of COVID, right? And there was a recognition that we have to deal with health equity. First thing out the box is like they're making it illegal to even talk about equity, about racial differences, these types of things. And then the next step was to cut staffing. Yeah. And so you don't have the support, you don't have the personnel support to deal with these issues. And now they're at the chopping block of the budget and investment, right? So, I do think, that we've had a few months to deal with the executive orders. Now we're in the policy conversations. And so I think the levers for change, I think people are, as I'm going to different parts of the country, people are recognizing, I need to talk to my state representatives. People who voted for Trump were like, well, I didn't vote to end my Medicaid. Like, I didn't vote to, lose this social service or to lose Social Security, right? Yeah. And so I think, I think we do have to, move with that moment. I think, the whole country's recognizing we didn't ask for all this. And, and I think the question is, how can, and I do think this is something all Americans recognize, that the importance of health care for all Americans, and we saw how devastating. I mean, it is still kind of amazing to me, the most powerful country in the world was shut down.
Yes.
For like a year and lost massive amounts of lives, and there's very little we could do about it. So, I think this is a time to, re-engage the community. It's been top down, the attack. I think the fight back's going to be bottom up.
Yes, and that loss has been disproportionate for the Black community. Let's not forget that. Representative Kelly.
I just wanted to say, if you can't sleep tonight, they will start the budget hearing at 1 a.m.
Literally in the cover of night.
So
they're going to be
so
taking
you will
this
be
bill
sleeping. And we did the healthcare part of energy and commerce. We started at 1:30 a.m. in the morning. So they are trying to sneak this stuff, by the public. But the thing they got fooled in ENC, that people in wheelchairs, Planned Parenthood, ACLU, they hung with us at 1:30, 2:30, 3:30. So 1 o'clock this morning, they're going to start, but they're going to be fooled because we have signed up to show up at 1, 2, 3, 4, 5. So the Dems on the budget committee will not be alone, and we'll be offering amendments. Like I'm going to offer my amendment again to extend postpartum coverage to a year.
And what's interesting is that we know that the southern states did not expand Medicaid. And when you think about and you hear about all of the hospital closures in the last 10 years, the largest part, 70% of those hospital closures, were in states that did not expand Medicaid. And Alabama is one of them. And it's unacceptable because what we're talking about is the Medicaid gap. People who are the working poor, they make too much money to be on Medicaid, and yet they don't have enough money to be able to afford health insurance. These are the working poor. And what they're doing is, in order to get the savings so that they can give this tax cut to the billionaires and millionaires, they're going to add on more work requirements. They want to now do it sooner. Instead of doing it in 2028, they want to do it in 2026. And so they're literally getting these savings by kicking people off their health insurance. We have to make sure that our constituency is full-eyed and aware of what's going on. When you think about the fact that nursing homes throughout America, 60% more are Medicaid funded. Medicaid funded. I just want to repeat, 60% of the nursing homes out there. Half of the babies that are birthed are Medicaid. And we know that Black and brown people are going to be the first to really, really feel this pinch. And in the greatest country in the world, I don't understand how, and the richest, I don't understand how all of these other industrialized countries can have universal health care and we can't. It's really unacceptable. My dad, I had my first surgery when I was studying abroad. It was a ruptured appendix. And I remember calling my parents from the emergency room, and my dad's like, do they accept Blue Cross Blue Shield? I said, Daddy, you don't have to worry about this. You will not get a bill. My dad went to his grave 3 years ago waiting on that bill for the ruptured appendix. And it never came. And I think I say that because it's my lived experience. I've seen in other places where it's done better. And we have got to figure out a way to make it better in America.
And also, don't be fooled. as far as Medicaid. 44% of the people on Medicaid work full-time. 20-something% work part-time. Another portion doesn't work because they're taking care of their family members. And there's very few people who just don't work. You know, they keep bringing up waste, fraud, and abuse. Don't be fooled. Ain't that much waste, fraud, and abuse, you know. But that's their excuse. And even what they do find is still not enough to cover, you know, the $4.5 trillion they want to, in tax cuts, they want to give to the well-off and well-connected.
Well, you're making an important point, which is also that messaging is important, right? How we talk about these issues is important. That's why, I'm going to keep going back to the playbook, y'all. That's why this is so important. How we talk about these issues and people understanding the domino effect is so important. So I want to pull us to two things. Since we're running out of time, we could sit here for hours, but I got a lot of things I want to get to. So first question is this. All of these things are interconnected. You all have already been talking about this. And Dedrick, I'm going to go to you. When we're talking about health, it is not just about health. You can't talk about health without talking about education, without talking about housing, without talking about Black wealth. So Dedrick, I'm going to start with you. Talk to us about how we should be thinking about connecting the dots on these issues and so that we can be prepared. And then also, Dedrick, talk to us about these executive actions, which are also now, these executive orders, which also now, everybody, are being released as presidential actions. Okay, we have to stay awake and knowledgeable. Presidential actions, unlike executive orders, do not have to be filed in the Federal Register. The Federal Register is how the public gets to know when new things come out from the government. Presidential actions don't. So we have to be very focused on these things. So talk to us, Dedrick, about how all of these issues are interconnected and how following and keeping a close eye on these presidential actions and executive orders is related to what we're talking about around healthcare today.
Well, I think, one common thing you can see is that, if someone's, doing something at 1 o'clock in the morning, and then they're like, well, I don't want anyone to know about this, so I'm not going to call it an executive order, I'm going to call it executive action. It's quite clear that they're doing something negative they're trying to keep from the public. And again, that's why it was so important for Congressional Black Caucus Foundation to have a website, because it's overwhelming, over 140. No president has ever done this many executive orders in the first 100 days. But a place you can go back and check, and what happened to that, what court has stopped, this order. So I think, really see a pattern. And I think, one thing you can learn from the executive orders, the executive actions, is it's kind of an indication of what they want to do policy-wise, right? And this is, again, just what they're getting into. I've spent my last 20 years or so focused on the racial wealth divide. And what I've, really come to understand, in the racial, I always say the foundation of racial inequality is racial economic inequality. The foundation of racial economic inequality is the racial wealth divide. But you have to understand that wealth isn't just how much you have in your bank account. It is also being in a safe neighborhood. It is also having access to health care. These are all of the assets that determine your wealth. And without wealth in this society, you really do suffer, right? And again, we talked previously about the COVID. It was amazing. My wife's a public health officer, and you think the richest, wealthiest country in the world, but how wealthy are you when she was sent to a Native American reservation to help deal with the COVID crisis, and the government didn't have masks to give the healthcare people who were dealing with people with COVID. She had to go to a local nonprofit, and they donated. So it's like the talk about waste, fraud, and abuse. I was like, we're cutting back, and and like again, actually, I live in one of the wealthier counties in the country, but go to the emergency room on a Saturday night. It doesn't look wealthy. It's people waiting for hours for basic injuries. And again, wealthiest country, wealthiest county in the country, and we still don't have those type of resources. So I think it's really important when people are talking about waste, fraud, and abuse and the need to cut. Cut what? Like our healthcare system is, what's that line where where they manage your health, and it's like if it goes flat, it's
the flatlining.
The flatline. Like our healthcare system for many people has flatlined. So how are we going to further invest in this? Not talk about further cuts.
So now, Representative Sewell, I'm going to go to you because my clock is ticking. I feel like I see Flavor Flav's big clock in front of me. Here's what I want to do. We have already laid out for everyone what the problem is. And we know we're going to walk out of here today talking about some of the solutions. But before we get to everyone else talking about solutions, I want each of you to tell us about a solution. We talked about executive actions and presidential actions and executive orders. Let's get marching orders. Yes. Rep Sewell, what's your marching order?
Well, I think all of us have a role to play. We as lawmakers must legislate where we can, litigate where we can, develop policy where we can. But the most important, I think, is public sentiment. Never underestimate the power of public sentiment. You know, the first thing that happened when they took away in the Air Force manual the Tuskegee Airmen, the history of the Tuskegee Airmen, we were all up in arms about it. We were and we let our voices be heard, and they reversed course. So don't ever underestimate the power of your own voice. So mobilizing and organizing where you are, organizing and mobilizing is so critically important to fight back. All of us have a role to play. Speak up and speak out. And that's why having this playbook where you have stats and figures and numbers to back up what you're saying is so critically important.
Representative Kelly, what's your marching order?
I associate myself with my colleague, but also I think that we need to work on changing healthcare so it's community-based, not from the top down, community-based. When you think about COVID, it was those trusted messengers, you know, the people that were hired to navigators that really made a difference. And I think that we need to go back to that and really look at, you know, the people that are closest to the issue and listen to them to solve the problems.
I love that. Dedrick, what's your marching order for us? Yes.
Yeah, my marching order is, you know, all of us are part of many different types of organizations, have different types of lives. Outside of here, I'm like a basketball father for 2 young girls and kind of running around the weekends engaging in this. How do you take other aspects of your life and bring them into the health equity conversation? Like, how do you bring that into the public schools conversation? How do you bring that into your church meetings? How do you bring that into even just your group of friends talking? I think, you know, that's really, we can't just talk to the same people. We have to bring in, we're all part of different communities. How do you bring these communities into these conversations around health, taxes, wealth, the policy playbook, you know, show this to everyone?
I love it. I'm going to give one marching order, but I'm going to remind you, I'm going to quiz you all later when I'm running into you in the hallways. You heard from Representative Sewell, speak up, speak out. You heard from Congresswoman Kelly, community-based, and you heard from Dedrick saying that we've got to pull all these issues together. My last marching order to you is this. Understand that wherever you sit, I don't care if you are a student. I met a wonderful student earlier today who's about to head to UNC, Chapel Hill. No matter, okay. We're not going to get into that one. But many of you, you're community activists, you're experts, you're scholars, you're medical professionals. I want you all to take back to your communities what you are learning today and ask yourself, what can I do right where I sit? You don't have to be an elected member of Congress. You don't have to be a president and CEO of a major nonprofit. Each of you has the power right where you sit to make a difference. So those are our collective marching orders to all of you today. Thank you so much to our panelists for being here with us and for their wisdom. And again, go forward today, make a difference, and let's create real change. Thank you all so much for joining us.
Please welcome back to the stage Vice President of CPAR for the Congressional Black Caucus Foundation, Dr. Jonathan Cox.
All right, greetings once again, everybody. Can we just give one more round of applause for our incredible opening panel? Yes, they did such an incredible job. Really, again, to each of those panelists, I want to thank them, right, in particular for the work that they're doing in their fields. I really want to thank Rep. Sewell and Rep. Kelly, right, because I'm just awed by their continued resolve, particularly in light of all the opposition that they're facing right now. They continue to be such huge champions for Black people and Black communities and America more broadly, right? So really thankful to them. And so now I have the pleasure of introducing to you all the moderator for our expert panel discussion, which is Prescribing Policy, Advancing Equitable Access to Chronic Disease Treatment, and that is Ms. Mariah Barber. Ms. Barber is the founder of Invisible Strengths, an HR tech company founded on intersectional disability justice. Barber is an author, certified health education specialist, DEI consultant, and researcher who has been working in public health for over a decade. And her work has been focused on the intersectionality between biological and social sciences on a global scale. Now, Ms. Barber herself is a multi-hyphenate. Her professional experience includes working as a radio personality, a spoken word artist, a content curator, moderator, mentor, researcher, counselor, right? If I was here trying to name off everything she did, we'd be here until the afternoon, before we were even be able to start. Her mission and mantra in life is some people do, some people never do, some people overdo. How do you do? I love it. Now, please welcome me, or please join me in welcoming, Miss Mariah Barber to the stage.
Greetings, everyone. How are you doing? Super excited to be speaking with you all today and hearing from our amazing panel around health equity. In times like this conversation is very much needed, and we're excited to get insights and just hear some profound ideas. We were talking in the back, and so I'm excited to see that conversation build. I want to begin by introducing our incredible panelists. So I'll start with introducing Dr. Ayanna Bennett, Director of the DC Department of Health. Dr. Ayanna Bennett is the Director of the District of Columbia Department of Health and a servant leader. She is proud to stand alongside so many other dedicated public professionals at DC Health. During her 20-year public health career, she has addressed health disparities and contributed to systematic changes to improve public health with sincerity, bold determination, and dedication. Let's give a round of applause for Dr. Ayanna Bennett. For our next panelist, I would like to introduce you all to Dr. Elise Akere, Assistant Professor at Johns Hopkins Bloomberg School of Public Health. As a tenured-track assistant professor at Bloomberg School of Public Health in the Health Policy and Management Department at Johns Hopkins University in Baltimore, Maryland, she completed her Bachelor of Arts in Psychology with a minor in Africana Studies from San Diego State University and an MA in Women's Health from Suffolk University and a PhD in Health Services Research from the University of Maryland, College Park. Working at the Centers for Medicare and Medicaid Services for Customer Information and Insurance Oversight from 2012 to 2020, implementing the Patient Protection and Affordable Care Act. After finishing her PhD, she completed a postdoctoral fellowship at Vanderbilt University in the Department of Medicine, Health, and Society at the LGBTQIA+ Health Policy Lab. Join me in welcoming Dr. Akere. Clap it up. We've got an incredible panel for you all today. And now I'd like to follow up by introducing our next panelist, Dr. Jean, President and CEO of Creating Healthier Communities. Dr. Jean is an accomplished leader and innovator in health equity, longevity, health systems, transformation, and building equitable systems so that every person and every community can live longer, healthier, and more productive lives. As President and CEO of CHC, Creating Healthier Communities, Jean leads a high-performing team that is dedicated to breaking down the barriers to health and empowering communities to thrive. With business acumen and a deep experience across sectors, understanding how to develop creative and actionable solutions, policies, and programs that uncover the economic advantages of addressing disparities. Let's clap it up for Dr. Jean. And then last, but certainly not least, we have our amazing panelist, Dr. Vivian Herrera, Vice President of Scientific Evidence and Policy Research at Johnson & Johnson Innovation Medicine. Dr. Vivian is Vice President of the Scientific Research and Policy Center, team with the Scientific Affairs at Johnson & Johnson Innovative Medicine. She is responsible for industry-leading research and strategic innovations for NA Pharm with an evolving U.S. healthcare ecosystem. Vivian works closely with the Scientific Affairs global and U.S. business partners, as well as external stakeholders as a strategic scientific partner, driving research to accelerate patient access. Her team is responsible for demonstrating the value of Johnson & Johnson's innovative medicines, technologies, and policy positions to patients, healthcare providers, payers, and policymakers with the goal of improving patient outcomes and access for all. Let's clap it up for Dr. Herrera. What in you all's opinions is the most significant barriers that prevent equitable access to chronic disease treatment for today?
I'll start. In my mind, whenever we're talking about equity, I always think systematically, and we have a system that is built, I call it on the bones of an equity. So our geography, our economics, we have a lot of baked-in inequities that mean when you try to do something, it gets rearranged by the baked-in inequities, and it kind of fleshes out the skeleton that's already there. So I think the fact that we have so many unaddressed inequities already in the system is a really basic principle that needs to be part of how we drive our actions around health equity. So, for example, any time you put something geographically, it has an equity impact because we are a largely still segregated society, especially in our urban environment. So if I decide to put something somewhere, it has an equity impact because it is either close to or far from communities that have issues with transportation economics, and those are all the same communities. So our history and the fact that it has persisted, I think, is one of our biggest barriers.
I agree with Dr. Bennett. I will just add another layer that we oftentimes create interventions and policies that are really individual-centered. Like, how can we change people? And oftentimes, I think that prevents us from really seeing that these are systemic, these are structural issues. So, for instance, we'll have a lot of interventions around diabetes and nutrition. And for some odd reason, the food that kept my grandmama and great-grandmama alive is somehow killing me. You know? And so it's like we start to focus on, well, don't eat this, don't eat that, do this, do that, but we ignore the larger things. We ignore chronic stress and how that impacts weight loss. We ignore the fact that people live in food deserts, what impacts the type of food that they can get. We ignore environmental injustice where people are walking outside, but they're near highways, factories, toxic areas. And so we create and invest millions of dollars into a program to tell me to not eat fufu, but in reality, we really should be focusing on programs that will start to address a lot of the other factors that are impacting my ability to lose weight and to be healthy.
Just kind of building off of this conversation, first of all, I'm just extremely honored that we're having this conversation here in DC at this point in time. So I just want to acknowledge and just thank the staff and the leadership over at CBCF for just your leadership and your vision and your courageousness to elevate these issues. There's a couple of things. I think one is just an acknowledgement that our healthcare system is actually a system that is based off treating illness and not necessarily based off promoting health. I think, and that's critically important, meaning the fact that when you think about our healthcare system, it's focused on three different elements. One is the payer, the provider, and the regulators. At no point does it talk about person and family-centered care. And the incentives don't align with that. In addition to that, we know that where you live has huge implications for how long and how well you live. In our country, we are seeing an average of about 20-year life difference in terms of life expectancy solely by zip code, oftentimes less than 5 miles apart. And when you start to unpack that, what you see are some of those structure issues Dr. Bennett is referring to: the disinvestment, the lack of education, the lack of access to food, the lack of access to healthcare providers, transportation, and the list goes on and on and on. That doesn't even get into mistrust and the trustworthiness or the lack thereof of the institutions that are supposed to be taking care of us. So I do think that as we have this conversation today, there's a couple of things that I would encourage all of us to do, wherever we may sit, in terms of really trying to reimagine how do we ensure that we actually close these gaps. The first one is to really say, what is the proximity first strategy within your organization? So for those who know Brian Stevenson from the Equal Justice Initiative, he says that you cannot be an effective problem solver from a distance. There are nuances and details you will miss unless you get close. So as we have this conversation and we talk about the lived experiences, and we heard this from the panelists earlier, we have to start to center the communities that we care so deeply about. And let's be clear, our communities are not broken. The system is broken that is supposed to actually serve our communities. So let's just be very clear about that.
Great, thank you. So I want to also first start with thanking President Nicole Austin-Hillery and CBCF for inviting Johnson & Johnson to this important health summit. And I also want to acknowledge our inspirational speakers right now, Representative Sewell and Representative Kelly, for their leadership, because having them as a voice is really inspirational for us of what we should be doing too, really to advance healthcare access and affordability. I'll take a little twist to what we've talked a little bit about here, and it's in thinking about from an insurance perspective. We know that in 2023, insurance was with patients at its lowest, right, in terms of how many patients and how many Americans were actually insured. And more outstanding was 23% of young adults actually had underinsurance, meaning they had insurance, but it really wasn't covering, what they really needed. And so when we think about that, right now there's a lot of pointed fingers into manufacturers of pricing. But the reality is that, as manufacturers, we've been lowering our net prices. And, with Johnson & Johnson, it's been, for the past 7 years, down to 20%. But what we see here is that these savings are not passed to patients. And so we need to do a better job of, how do we ensure that patients really are sharing that part of, the savings. We see a lot of, in terms of when we look at net prices, the reality is that right now, those costs are looking at list prices. And so that's what we need to have the conversation kind of turned around to in terms of like what those barriers would be.
Thank you for all your insights. I think that we can all agree that systems are operating just as they should. And I love hearing about how you all are being disruptors in the space and pushing forward health equity from a manufacturer's perspective to health department policy, and even in the private sector. I want to kind of build on what Dr. Herrera was saying, and just going into a bit about the biggest policy levers related to insurance. With coverage and reimbursement policies, they deeply influence what revolves around care and who receives care and when. So what reforms, in you all's opinions, are most urgently needed to ensure that insurance systems don't reinforce inequities, particularly in the Black community?
So there's a couple of things that come to mind. Deloitte actually came out with a study that demonstrated that health disparities cost the U.S. about $320 billion in 2022, and if we did absolutely nothing, it would be over $1 trillion by 2030, which is about 5 years from now. AARP, the organization I came from, we did a study with the Economist Impact, and we found similar points, meaning the fact that we did absolutely nothing to address these issues, that it would actually cost the country significant dollars, and as a result, everyone would suffer because of these inequities. I say this for 2 points. One is the fact that there's a huge conversation taking place, and we heard from our members of Congress around the reconciliation process, and that if members of Congress are actually very serious in terms of about addressing the deficit, that this is an issue in terms of addressing health equity that has to be centerfold, because that we know that when we actually ensure that every single person has an opportunity to live their healthiest life, that means that they can actually contribute back to our economy, they can actually do the things that they care deeply about, and everyone benefits as a result of that. Every single person benefits as a result of that. The other aspect of that is because of the fact that this is also a national security issue. If you have a population that is not healthy, it actually puts all of us at risk. So the policies that are being discussed on Congress, I think, are very critical in terms of exactly our economic as well as our national security. And then to answer your question more specifically in terms of what are the levers that we need to start pushing. We were talking earlier because we just realized we both worked at the Centers for Medicare and Medicaid Services. And if you look at those two programs, they're major drivers of innovation and the ability to actually scale. But there's also systemic barriers that we need to address, both in terms of provider networks, in terms of high deductible cost barriers, in terms of exactly needing to get prior authorization for certain benefits, right? All of those actually impede people's ability to actually get the access that they need. So you can have coverage, but that doesn't necessarily mean that you have access. And I think that's critically important for us as we actually go down this path. The last thing I would say is the fact that we need to think about this through a multi-sectorial approach, meaning the fact that it does require partnership with business, partnership with nonprofit organizations, in part because of the fact that no one sector can solve this in isolation. And if we truly care about meeting people where they are, then we have to be proximity first. And that requires all of us. And I just want to acknowledge really quickly one example. So we have with us Dr. Sandra Nichols, who's a civil rights advocate, health advocate, who actually is the founder and CEO of the Samaritan Health Project, Inc. And it actually is doing tremendous work in Little Rock, Arkansas, a red state, in rural. Pop-ups, conversations, bringing together the right and the left, and business with the community at the center. First by saying, what do you need and what are your challenges? And then also what are the opportunities to drive systemic change? That requires partnership and that requires courage.
I will say I think we were on the cusp of solving a lot of these problems. We were in the middle of conversations about prior authorization. There was a lot of innovation around removing prior authorization, about removing copays in areas where we knew we had high racial disparities. And I am old enough to remember telling patients, I think you have cancer and you have no insurance, and we all get to spiral in despair about what to do about that. And I'm a pediatrician, so my patients were not old. So the idea that any segment of the population is going to return to that state, and we are going to then be relitigating problems from 15 years ago instead of talking about copays and prior, because if we have a large segment of the population become uninsured, we will not be talking about those things. We will be talking about people who have very little option in a world where they are unhealthy, and we are just going to be suffering through with them how to do anything about that. And I just want us to understand that that is the magnitude of the decisions that are being made right now. It is whether or not a population that has really almost, I think, forgotten what it's like to have a huge uninsured population. We had moved so far forward. I think it will be a awakening. There's a whole generation of people who did not have that as a central part of their careers, who are going to, I think, have real trouble trying to practice and move policy and things forward in that environment. It was not fun, and I am not looking forward to going back there.
I would also add, I think it's critical for us to also pay attention to loopholes, right, that can happen where certain benefits are set up that really look like they're going to help the patient, but when you actually look into it, or the way it's being implemented is not quite there. And this is where I would say we need to try to prevent things, for example, like patient assistance, diverse programs, right, where they're being set up in terms of things like maximizers and life plans, where you're actually, instead of taking the copay assistance programs, for example, that manufacturers like Johnson & Johnson provide, right, to patients for copay assistance, are not being applied to their deductibles. And so that doesn't help the patient, right? Because the reason for setting them up is to help these patients, but they're not being applied to their cost sharing. And so we need to ensure that we're looking into these programs when they're set up. And for example, right now we have 19 states that have set up laws to actually prevent that. We want more states, right, to speak up so that really the cost sharing for patients is truly, a share for the patient and not, sent to other.
There were just so many gems that were being dropped. So I want to thank everyone for their insights. And one thing that stuck out that we all kind of discussed was breaking down silos and really reaching across to other aisles, other industries, other disciplines to come up with these solutions and trying to prepare for the potential of going backwards. And so I wanted to step into that a bit more with our next question, and talk about how access to care doesn't happen in a vacuum, right? So as we consider the broader context of health equity and social determinants of health, which we've touched on, place-based things like income, housing, and neighborhood access, they often shape treatment outcomes. And so how should healthcare systems and policymakers better integrate these realities into chronic disease strategies that they're using?
I just want to point out that we actually have two systems. We have a medical system that delivers direct care, and we have a public health system that is mostly run by the government, some nonprofit, some other elements, but those two systems support health in this country, and they depend on each other. So most physicians depend on the fact that there's some kind of food assistance in the world. They don't have the expertise or the resources to duplicate WIC. They just don't. I've heard from many a foundation in the last couple of months that they can't backfill the federal government. Well, neither can your medical community. No one can backfill the federal government. So if those programs like food assistance and public regulation around restaurants and cleanliness and all of these things that make, once you walk out of the office, make you not get sick from 50 other things, that system has to also be there. And so I think that's part of the balance, is how do we make sure that we have both sides of the system. And we are losing some of that side very aggressively right now. And there is no way to just duplicate that on the other side, especially not at scale in any kind of time frame. So we're approaching gaps already. And I think being able to have the systems work together, I'm not sure everybody's as aware of how interconnected and interdependent it all is until now we all suddenly realize as parts of it are going away. So like the medical community in Milwaukee is not going to make up for the fact that they're no longer a federal lead expert working on the fact that they have lead in their schools. That there's no way for them to do that, but they're going to have to figure out what to do with all of these kids who now need to be screened and treated for lead, but they can't do anything about the prevention side of it. So there has to be a balance, and I think that it's being threatened right now, and I don't know that either side can really balance out for the other. They do both have to be there.
Go ahead, Doc.
Yeah. These are like very wonderful points. And when I think about so my answer is like 6 months old. So thinking about like now and what we could be doing. There was just like a lot of times when I talked to clinicians and providers in the space of my work. Like, I am not a clinician. I'm more of an interventionist, implementation scientist, trying to find solutions. So thinking about ways we can work together. And one of the things that comes up a lot is that, again, to your point, there's this public health and medical divide in a way, and while they need to work together, there isn't a level of shared accountability and collaboration. So oftentimes I'll hear about a program where we're trying to do more hospital at home or more home and community-based services so people can kind of stay out of institutions, stay out of nursing homes, stay out of hospitals. But oftentimes in the medical setting, they're like, well, we don't know how to reach people who need us most. And then in the public health setting, there's like, well, when people call us for resources, there are wait lists, there are lines. And so it's like there's just this lack of connection across the two to find ways that they can collaborate, share incentives to be able to reach the community in meaningful ways. Everyone has the best intentions, but again, those silos that are experienced there where people just don't know what's available. For instance, there was a program where they were giving free genetic testing for breast cancer after breast cancer screenings. And we did this study where we were trying to understand why certain providers weren't offering it to their patients. And it was simply because they didn't know. They just assumed they couldn't afford it because it was a very expensive test, and they're working with different populations, Medicaid patients, and they're like, well, you can't afford it. Wow, they bring up this wonderful thing that you can't have, when the whole time there was a post-it on the memo board that said, this is now free. And so when we talk about like our lack of communication, our lack of coordination, our lack of shared incentives, it's like there's a lot of desire, the best intentions are there, but really finding ways to coordinate those intentions, coordinate those resources so they're not duplicative, so we're identifying our gaps. These are things that we can do practically to try to help encourage our medical and public health systems to work together to improve health outcomes. Yeah. Oversimplification, we can dive into how to do that, but I think that's one thing that's really is missing.
I would just add that I actually don't think we have a system.
I needed to call it something.
I don't know what we
All right,
have.
Fight me, sir. I'm your system. I have a system. I'm just going to tell you, I'm going to go back to work and tell all the people you said that about them. This is off the record, it is broken, but we'll notice we have a system when it's half of it's gone. Yeah. And then you'll know.
That's my point.
You'll know it was there because we'll notice it's gone.
And that's my point, right, Dr. Bennett, is the fact that currently, we assume, and I think right now we have an opportunity, given what we're collectively going through, to reassess our assumptions. Mm-hmm. And what I mean by that is the fact that there was a time I thought that we could just say this is the right thing to do because everyone had the best of intentions. I think we're in an environment with the executive orders or directions or whatever label we want to call it, that we have to start to reassess our assumptions about exactly what is driving the decisions that we're seeing. And I just want to sit on that for a second because I think that's critically important. We used to say that this is a moral imperative, that this is a social good. But that argument clearly is not working. Right? So I think that where I'm taking it, Dr. Bennett, and I totally agree because I love my providers and everything else. But where I'm going with it is this, is the fact that we have to look at the financial incentives and say, how do we start to align the financial incentives to the behaviors that we seek, right? So in other words, to what extent, and there's different models for this. So the question for us is, how do we start to scale the things we know is working? So whether it's the Camden Coalition, where they actually focused on individuals who were constantly going into the emergency room and realizing that what was going on there was that individuals did not have access to food, housing, and some of the social drivers that are critically important for us to live and age well. And they integrated primary care with social services in a value-based purchasing type of model. And that, what we saw was a 40% decrease in hospital readmissions, right? Or what you're seeing in Minnesota, where they're actually tying bonuses to providers who are actually reducing disparities. It's not to say that they're not doing it for because of the right reasons. What I'm saying is the fact that we have to start to reassess our assumptions and think that there are those who actually think this is a good thing to do, and then start to use language and insights around what are the financial incentives to drive the behaviors that we want in order to see the kind of care that we all deserve.
I would just say that CMS has been one of the best innovators in this space, and that value-based payments are the biggest gift to public health and health equity if we use them. If they persist, I'm not sure if they will, but if we use them, and that a lot of the things that have come out of CMS, from value-based payments to now health-related social needs and those payments in Medicaid, that there is actually a lot of solution-making happening at the federal level that, if when it's implemented fully, has actually had a real impact. I don't think we have stopped to assess and make the best case for that, but it has been very true. And the idea that you can't get paid the same amount if a big chunk of your population is doing terribly, that's CMS, that was our federal government doing that, not altruism. And they did make it so that it actually was financial, and translating that into cost has actually been, I think, a real sea change for the way health systems and insurance companies think about who is in their population.
And it's really important to also be mindful of what can occur when we do that, because I think that like there's this this combination of like, okay, we have these value-based models, but what we also started to see was people starting to sort different patients who are more problematic into lower quality hospitals. So the folks who are treating the most high-risk individuals and folks with the most needs were getting penalized the most because they had the quote-unquote worst patients. Or we see some gaming where it's just like CMS created a payment for dementia diagnosis because we have an underdiagnosis of dementia. And so eventually they said, okay, well, there's this additional payment and additional suite of services if you have a diagnosis. All of a sudden, everybody got dementia. Now, do we have dementia? Yes. Is everybody who really needs the care and needs the services, are they getting their diagnosis? No, because there's oftentimes this sorting, this gaming, so you can get that extra 2%, extra 3%. And so it's just like it's balancing. Yes, we do need to have financial incentives because capitalism is king. It's not going to change tomorrow. If it does, let me know. I got some body butter I can barter with you for, so I get some services. But until that, hey, listen, got two skills. One of them is body butter. And so when we think about like how we navigate these systems the way they exist, it's also thinking about how are we going to hold them accountable?
Yes.
Because there's a lack of accountability in a lot of spaces. We provide, hospitals have nonprofit status. They receive billions of dollars in tax incentives. But when you run the numbers and look to see whether or not they're actually impacting the health of the communities in their surrounding market areas, there is no connection between the two. So we've lost billions of dollars in tax revenue that would have gone to the states, would have gone to the areas to improve the social determinants of health, but they're going to hospitals that aren't impacting the health outcomes of the communities. It's starting to it's starting to really interrogate and assess how we're leveraging our financial incentives, because we've given billions of dollars away in Medicare Advantage for these accountable care organizations to try to improve healthcare access, but we don't know there are huge disparities in the quality of care that people are receiving. Billions of dollars still going out, equity not coming in. So there's we need to still be on top of folks. We need to still assess what we're doing, because while this is the way of the world, it isn't working, And so we definitely need to challenge these things as we incorporate new innovations. Because you're right, CMS, CMMI have done some amazing things, but it doesn't stop there. We have to continue to be on them, to hold them accountable, and to leverage our voices in all of these spaces, whether it be locally, whether it be federally, whether it be how we place our vote. Because oftentimes when we don't see the immediate 365-day turnaround policy, did it work or didn't work, it's a slower investment. It's a slower ROI for health equity. It's not going to change overnight. It took 15, 20 years for us to say, wow, we have lower uninsurance rates. It took 12 minutes to undo that, but it takes time for us to see the impact of it. And if we sit here and say, oh, it didn't work because we didn't see it, well, if we didn't wait, we couldn't see its impact. It's like weight loss. You did your 4 weeks, sis, person. But keep pushing, because it takes more than 4 weeks.
Yeah. I'll just quickly add, because I know you have more questions. I think, but at least it's the right path, right, of looking at value in terms of outcomes versus value in terms of cost, right? I think part of it also is, choosing the right outcomes, right? Because that's the other part where, some of the hospitals are incentivized for certain outcomes, but are those the real or the true outcomes that we should be looking at? So.
That's a very good point. There are some quality certifications where providers can pick what they want to report on, and it's like, well, if there isn't a standard of if we don't have outcomes that are actually aligned with our intentions, we could. If you want to say, am I the best professor in the world? Yes, I am. What are your standards? Mine. It's like, how does that work? But if there are objective standards that are evidence-based, that are tested, we can really have a conversation. And to your point about dismantling those things, that's what's happening. Our ability to identify evidence-based interventions, our ability to test the outcomes of these different quality metrics, those are being challenged every day. And if we don't have the tools and the resources to hold folks accountable, where does the accountability come from?
And want to build on your professorship, Dr. Akre, and I need to talk to you about that body butter after this too. But I wanted to just ask you about your research at Johns Hopkins, focusing on health equity. And if you could discuss briefly how systemic factors affect the treatment and adherence and even outcomes for Black communities.
And you could probably tell I could be quite wordy, so I'll keep it short on this one. More specifically, there's been a lot of work that I've been looking at to really understand the multifactorial issues that are impacting healthcare access. Because to your point, for more folks, like we've had a lot of folks having insurance, but we recognize that folks just aren't using it. We have folks who are going to the hospital, but studies demonstrate that Black and brown folks end up at hospitals with lower quality, higher mortality rates, more issues of readmission, lower CMS quality scores. And so in one of these studies I did, I looked at I created a local hospital segregation index because I wanted to know, because segregation is illegal. And every time you read these studies, they're like, oh, the reason Black people go to bad hospitals is because they live next to bad hospitals. And I was just like, well, that's not true. Because I know like word of mouth is huge. If everybody, like back where I come from, I'm from Los Angeles, Martin Luther King Hospital, they shut it down, but it used to be off of Crenshaw. And it's like, if someone's like, oh, I'm going to King Hospital, it's like, you're not going to Killer King, that's the worst hospital ever. I know people who've died in the emergency room there. You should go here. We do that for each other. And all of these studies were like, well, no, they don't. They just say, ooh, Black doctor, I'm going there. And it's like, it's more than that. And so I decided to try to interrogate that and then also take it away from this individual thing. Like every individual Black person is making the same decision. Like, no, we're way more multifaceted than that. I can't make the same decision as my sister. We got the same parents, you know? So it's just like, when I started looking at what is happening, we found that no matter, like, even when Black people live closer to a high quality hospital, they're ending up at somewhere further away from their home and lower quality. And then when you look at that relationship between a hospital's, the idea was, what should a hospital look like? And it should look like the people in its market area. So we essentially created a score where if you were a hospital that had, let's say, 10% Black people in your area, you should have 10% admissions for people who actually went to the hospital that year. And so we did that, and we found that the more a negative score was, that is, you had less Black people than lived in your area, the higher the quality was. So every time you were sorting Black patients out, y'all can go there, and had less and less of a represented amount of Black patients, your score was better. The more overrepresentation of Black patients you had, the worse your score was. And then so I remember I was at this conference and someone was like, well, is it because Black people are sicker and that's why they're worse scores? Because of the conference, I said, no, I'm going to come back with some evidence. We looked at it, and mortality score goes into quality. But we found that when there was an overrepresentation of Black patients, mortality score was lower. They were actually better. And it was kind of like, okay, so Black patients, so what was killing the score? It was patient experience. It was using the efficient and effective tools and resources for that patient. Did they get the right thing when they needed it? Like those types of things. So we found that it was, when you look at the nuance, it was folks who were being sent to places that were further away from them, and when they got there, they were worse quality. And how does that happen? That happens because of policies. That happens because of policy with lowercase p, like what's happening in a hospital, how we treat certain patients. There are certain studies that it happens in ambulances. They assume where you can go and start taking you to certain places. And all that was beyond my decision. All that is beyond what I was telling my friend, don't go to that hospital because this is happening there. There are better providers here. And so what I've been learning in my work in my research is how do we disentangle these things so we can identify them, so we can call it out and hold people accountable. We can say, hey, this hospital gets an extra value-based bump because but we don't realize that it's because they're pushing Black patients out of their hospital. Now they need to be held accountable for that. And so the research that I'm doing is creating accountability tools that already exist, but leveraging them or using accountability tools that already exist in new ways so that we can hold people accountable in ways that are meaningful, i.e. aligning our outcomes with what our intentions are. I apologize, that was not succinct.
No, thank you so much. I want to uplift, I'm hearing trends of talking about how do we hold people accountable how do we align our intentions with the outcomes? And we've really been able to touch a bit on data. I'm coming to you next, Dr. Bennett. So just wanted to bring data and metrics into the conversation. And I know giving your leadership at the DC Department of Health, I just wanted to hear a bit more about how data collection and analysis help identify and address inequities in chronic disease treatment. And how can this data be leveraged to inform smarter, more equity-driven policy decisions in the future?
So we have two kinds of data that we all use, and I will say that our understanding of who has disease and what their outcomes are is better than our data on what happened to them to some degree. And the two don't necessarily get attached to one another. What I mean by that is we have very good data on rates of hypertension, mortality related to that, and we know that there's a clear disparity there. I don't know that we are as robust about how hypertension control, which is a thing that we can achieve through care, how well the disparity we know about there aligns with our outcomes. And that is partly because while we do get payer data, that is about what you ended up doing. It doesn't have the underlying information in the medical chart that would tell you whether that was appropriate or not. And so we look at these kind of big differences in whether or not people ended up on medication or whether or not people got hospitalized and it seemed an unnecessary hospitalization. But I think there is a deeper level of data under that about what our decision making is like that would tell us more, and that's what I'm hoping we can start to build. I've been talking to CDC and others for my whole 2 years here, trying to get some of that built, and we have a lot of hope for that in DC because we have one health information exchange that is the entirety of DC, which is unlike what most states can achieve. So I'm looking at how to develop that. A lot of the underpinnings of the funding that might have gone into something like that are really questionable right now. But the idea is, when I was the Chief Health Equity Officer in San Francisco, I don't think I ever saw a system that we looked in which people were being treated exactly the same. My thesis now is that inequality is unequal quality all the time. It is always unequal quality. We know how to do quality, we just don't do it for everybody. And that's just how we do it. Yeah. I have benefited from a ton of goodwill. Whenever people are told that's what they're doing, they almost always make some effort to stop it. But we have to have the data to tell people that that's what they're doing. Yeah. And so trying to do things like equalize hypertension control, we spent a lot of time and money on that in this town and saw some good impacts. Just recently, we tried to do that with breast cancer and saw that with a lot of navigation and extra support, we could get the wait time for our folks in our public clinics down from 68 days from diagnosis to follow-up down to 28 days. But that is 40 extra days from not having resources enough to get people where they needed to go. So all of those extra resources, all of that data that says you're not getting what you need and you are, that system is really nascent and not very well developed. And the impetus to develop it more, I'm not sure is still there. But until we do, we will not correct the differences in behavior, not patient behavior, but system behavior that have led, I think, to a lot of our inequities. Chronic disease is treatable. Mm-hmm. It's treatable. There should not be a 20-year life expectancy difference that is very heavily attributable to chronic disease outcomes in an environment where we have statins and effective blood pressure control and essentially can treat most of these illnesses, not cure them, but certainly treat them more than letting people die 20 years before they should. So we need the data. It's sitting there. Are we built to use it just yet? No.
Yeah, and I would add to that, Dr. Brandon, because I think that's really a really key point. Like, When you even look at what patients are prescribed, right, and you look at your EMR data, very different from what they actually fill, right, from your claims data. And so already you see the difference in behavior there due to insurance benefit designs, et cetera, that kick in. So definitely to be able to see that full picture becomes really important, right? To see about that.
Yeah, seeing the whole patient is incredibly important. And I know data is part of the story. And also, Dr. Herrera, from your industry perspective, can you walk us through with Johnson & Johnson how they're approaching partnerships to not only drive some of the innovation we're talking about, but also intentionally expand access to treatment for Black communities?
Absolutely. So again, from my perspective, I lead a research team, and as we were talking, evidence is really key, right, from making decisions. We currently have a program, My Health Can't Wait, which is a community program for Black people that what it does is give access to screening information and resources and vital health information, and really gives that possibility of having that voice within your own, to be able to drive those health inequities, right, and understand what those health inequities are. Furthermore, we partner with large, provider networks, also health systems. We've done also, for example, in psoriasis and moderate to severe psoriasis, really, identify some of the issues there in terms of, thinking that skin is just skin. But the reality is that when you think about, Black people, Hispanic people, you have different types of skin and different colors, and then being able to understand what clearance, right, skin clearance is, and being able to objectively identify that skin clearance piece is really important. And so we have a program also on Visible, which actually identifies across all the different skins what could be those manifestations. So that's been really important for patients in psoriasis. Furthermore, we also work with, like I said, with big provider networks to help population decision makers understand inequities. And so you were mentioning the genetic testing, and we just had a study done with a large provider network on genetic testing, and what you see is astounding, and it's not surprising though. For example, Blacks, it takes from time to diagnosis to an actual testing is a really long time. It's almost 300 days compared to others like white Americans or even Hispanics. And then the time from time from testing to treatment is also very long. And so what this brings is that that gap, right, that we have of really educating our patients to really search for those screenings and for that genetic testing, but also the providers, right, in terms of talking to the patients. And the last one I'll bring up is in IBD, in immunology bowel disorders, we actually had a partnership with Ochsner on really talking about cultural sensitive kit, which is for providers to understand what those cultural pieces are and being able to talk to the patient and helping patients and providers have a better discussion versus just considering, as we talk about averages and stats, we're not a number. Every patient is unique. And I think that's one of the things from a Johnson & Johnson perspective, that we really have that responsibility of making sure that we treat patients as unique patients, that we have cures and treatments for, patients across, the globe and across the U.S., but really treat them as all unique. So,
thank you so much. And I know we're wrapping up here, but I wanted to just give a moment for this final question. And if we could keep it to a few words from each person. I really love the insights and the perspectives everyone's brought to the panel. So given the realities that we've discussed about the social and political circumstances we find ourselves in, I know many of us are hoping and planning for a more positive future, though some things look bleak at this moment. If there was any bold policy change that you could make tomorrow to meaningfully improve equity and access to chronic disease treatment for Black Americans, what would it be?
I'd like people to be able to get continuity wherever they are, wherever they choose to show up. So we're still a little bit of a hangover of primary care is best, but I don't care if you go to urgent care or you get it by telephone or whatever. I want us to equalize access, whatever the format that somebody finds palatable or available. So equal payment and equal access across whatever modality.
Something akin to that, removing the financial barriers to accessing healthcare. You know, we let some economists say moral hazard was like going to make us all rush to the hospitals and use it way too much. And then we created these barriers where it's just like now we can't even access them at all. And so we just removed a lot of the financial, actually all of the financial barriers to accessing healthcare. That would be it. How do we pay for it? Don't worry, we find a way to print money. We'll be all right. But for the most part, if we could do that, that would be the beginning of it.
I think that just given the conversation that's taken place around Medicaid, we actually at CHC released Medicaid Diaries as an opportunity to tell the lived experiences of people who actually are on the Medicaid program. And I think in this environment, we have to humanize the lived experience with the data, with the hopes that can actually change some minds. We know that the Medicare has the ability to negotiate drug prices and then also cap insulin. And I think extending that particularly to Medicaid and commercial markets, I think is critically important. The other thing I would just quickly mention is the fact that leveraging Medicaid to invest in the social drivers of health, I think is critically important in order to address many of the things that Dr. Bennett talked about. So now, if anything, just call your member of Congress and do all we can to try to preserve the program and then look for ways to further innovate.
Yeah, I think from my perspective, I think we want to make sure that we're focusing on one of the issues, right? And I say one because if we could go on, but I think the out-of-pocket piece, you know, where patients are really struggling, and when I say patient, all of us are patients, right? And it's not letting ourselves kind of get on focus on government price setting, because that's not the answer for the out-of-pocket. That can actually cause issues in terms of access and how cost sharing continues, right, to not be shared with the patient. And I would say, I think, also very important to really look at the patient as a holistic, right? And so really looking at value of medicine versus just pricing. And for us to, again, not lose that perspective, right, as we're having all these conversations. I think, you know, we continue to drive, and it's really important to drive innovation. You know, as a company, we strive, right, to have, you know, innovative medicines for patients, and we want to make sure that that continues. So I think it's, you know, making sure that what we're focusing is truly on what is the concerns for patients, like things like out-of-pocket patient.
Yes. Thank you to everyone. Dr. Herrera, just want to highlight that you said we're all patients, and we've been speaking about advancing chronic disease care, and all of us, if we live long enough, will become folks who are experiencing chronic disease as our cognition and mobility changes. So we're not only talking about the future of medicine, but our future selves. And so just want to thank everyone for their insights, their perspectives, and if we could give a round of applause for this incredible panel. Thank you, everyone.
Hello, everyone. What an informative and engaging panel discussion. Can we give our panelists another well-deserved round of applause? I also want to give a special thank you to our moderator, Mariah Barber, for guiding us through an insightful and thought-provoking conversation. As mentioned, the topic of access to treatment is especially critical for Black Americans. The dialogue we just experienced was not only rich in information, but also grounded in strategies that we can take back to our communities. And that's really at the heart of this work, ensuring that what we learn here today does not just stay in this room, but is carried out into our roles, not only as leaders and professionals, but also as caregivers, neighbors, and community members. This has already been a powerful morning, and we're just getting started, folks. So up next, we have our networking lunch and our health fair. In just a moment, you can make your way outside into the main hallway to grab some lunch. And throughout the hallway, you'll notice our health fair. This year, our health fair features an incredible group of vendors offering resources, services, and some great giveaways. It will be open throughout lunch, which will be about 60 minutes, so please take some time to visit the tables, ask questions, and gather information and tools that you can share with others. We will also have a table that's specifically dedicated with the resource guide for impacted federal workers, as we know that they are a big group, an important group in our community. I also want to encourage you to connect with each other. This summit is filled with people doing really important and impactful work. So don't be shy, we're all friends here, so introduce yourselves, share ideas, and build relationships. So we know that this work happens in community, and we are all part of the change towards collective action. One thing that I want to note is that, again, the lunch and health fair will go on for about 60 minutes. You can bring your food back in here if you feel like you don't have enough time to come back in time for our keynote session. We will also transition at 2 p.m. to our breakout sessions. Please stay for our breakout sessions. We have 4 really important, really engaging breakout sessions that are happening at 2 p.m. So pace yourself, stay engaged, and make the most of what today has to offer. Thank you again for being here and showing up with your time, your commitment, and your energy. I hope the rest of your day is just as energizing and inspiring. Enjoy. Have a great one.
Good afternoon, everyone. I hope you're well fed, ready to settle in for this fantastic keynote. I am so excited to introduce to you all Dr. Uche Blackstock. Dr. Blackstock is the founder and chief advisor of Advancing Health Equity, appears regularly on MSNBC and NBC News, and is a former associate professor in the Department of Emergency Medicine and the former faculty director for recruitment, retention, and inclusion in the Office of Diversity Affairs at NYU School of Medicine. She is also CBCF's National Racial Equity Initiative for Social Justice Task Force member. Dr. Blackstock founded Advancing Health Equity in 2019 with the mission of partnering with healthcare organizations to dismantle racism in healthcare and to close the gap in racial health inequities. She was recognized by Forbes magazine in 2019 as one of 10 diversity and inclusion trailblazers you need to be familiar with. And in 2020, she was one of 31 inaugural leaders awarded an unrestricted grant for her advocacy work for the Black Voices for Black Justice Fund. But that's not all. Dr. Blackstock has received numerous awards and honors, including the American Medical Women's Association's 2021 Presidential Award, the 2021 Harvard Humanist of the Year, the NAACP's Brooklyn Chapter's 2022 Valiant Service Award. And her writing, including numerous op-eds, has been featured in the Chicago Tribune, Scientific American, the Washington Post, and the New York Magazine. Dr. Blackstock received both her undergraduate and medical degrees from Harvard University, making her and her twin sister the first Black mother-daughter legacies from Harvard Medical School. Applause for that. And in June 2021, Dr. Blackstock signed a book deal with Penguin Random House Books for her generational memoir, Legacy, A Black Physician Reckons with Racism in Medicine. And if you haven't read it yet, you need to go buy it. Legacy was published in 2024, an instant New York Times bestseller and available for order. Dr. Blackstock currently lives in her hometown of Brooklyn, New York, shout out Brooklyn, with her 2 school-age children. So please give a round of applause for our keynote speaker, Dr. Blackstock.
Thank you for that intro. And actually, I have 2 copies to gift to 2 people in the audience, preferably the youngest people, when I finish, because I wrote this for my younger self. Okay, so excited to be here. Thank you for having me. So my keynote, just to give you a heads up, is a mix of storytelling and data. There's Dr. Blackstock. Hey, Doc. Doc, come over here. Oh, thank you so much, Doc. Oh, they're the Blackstock girls. Your mother is amazing. This was what my twin sister Oni and I heard as we walked through the hospital with our mother, Dr. Dale Blackstock. The year was 1986, and our mother was a physician at a public hospital in Brooklyn. Oni and I were about 9 years old as we witnessed our mother, a Black woman physician, being beloved by everyone in the hospital, from her staff to her colleagues. Even her patients were giving her a hug. Now, how many people are hugging their doctors? My mother was a petite woman. Oh, can we just put the slide? Can you change to the slide? Yes, thank you. My mother was a petite woman who wore her hair, natural hair in a top bun. She was kind and warm, but when she was with her patients, she would be focused. She listened to every single word that came out of their mouths. After all, she'd grown up in the same Brooklyn neighborhood as her patients, and she understood exactly where they were coming from. She would ask them about their family and friends. She really wanted to know her patients well. When you came in for a visit with Dr. Blackstock, you weren't only having your blood pressure or cholesterol checked, you were also meeting with someone who was assessing how your whole being was faring. I believe our mother practiced what is now known as structurally competent and culturally responsive care. This means the entire complex nature of the patient's background and the social context in which they live, work, love, and pray is considered during evaluation. And her patients, they loved her for it. She was always bringing home little gifts from them, a knitted shawl, homemade cookies, or a cake. You won't believe this, but growing up, I thought every single physician was a Black woman, like my mother. So she used to take my sister and me to meetings of a local organization where she was president. Where a small group of physicians who looked just like my mother would discuss programs and projects in our Brooklyn community, diabetes screenings, hypertension programs. They were practicing health equity even before the term was coined. My sister and I would situate ourselves in the back of the meeting room, making sure not to make any noise, and not really understanding exactly what they were saying, but knowing that there was something very important that was going on. When we got older, there was never a discussion that either of us would pursue anything other than medicine. Our mother was amazing. She was our role model. We wanted to be just like her and her peers. They were our reality. But when I got older, I realized that this was not the reality. Most people don't have this experience. While I was fortunate to grow up with a mother who was a physician, it's also important to understand that my mother was a rarity, as I still am. Sadly, the number of Black physicians in this country remains stubbornly low. 5.4% of all physicians are Black. 2.6% are Black men, and 2.8% are Black women, although we make up 13% of the population. What's even more appalling is that there's a smaller percentage of physicians today who are Black men than in 1940, when they made up 2.7% of all physicians. How does this happen in 2025? How does this happen? Call out, you can just call out, say what. Yes, okay, thank you. Well, I'm gonna tell you a little bit of history. For hundreds of years, racist practices and policies kept Black people out of medical schools. It actually took thousands of injured Civil War veterans in the North for white medical students to even consider accepting a handful of Black medical students. In the South, it was only after Reconstruction that Black medical schools opened. Meharry and Leonard medical schools, to name a few. By 1905, those Black medical schools had trained about 1,500 Black doctors. Each of those doctors was poised to train a new generation of doctors, and so on and so on. Doesn't that sound really promising? So what happened, right? What happened? Does anyone know? Yes, the Flexner Report. So a report named after Abraham Flexner, 1910. So let me tell you a little bit about Abraham Flexner. He was a white education specialist. He visited over 155 US and Canadian medical schools. He was also an avid racist with power and influence. The American Medical Association and Carnegie Mellon Foundation sponsored his work to look at the state of medical education. He once wrote, "Not only does the Negro himself suffer from hookworm and TB, he communicates them to his white neighbors." He believed that Black people were dirty. His report led to the standardization of medical schools. So he compared every school in the country at the time to the top one, Johns Hopkins in Baltimore. But this process required medical schools to have the resources and wealth to maintain quality education. Black medical schools didn't have that. Why? Why? Funding, right? Because of the legacy of slavery and systemic racism. So guess what happened? That report led to the closure of 5 out of 7 of those historically Black medical schools, leaving behind Howard and Meharry. Fast forward to June 2020, in the midst of a global pandemic and the Black Lives Matter protests, an article came up in my Twitter feed. It estimated that if those 5 medical schools that were closed in 1910 had remained open, they would have educated between 25,000 and 35,000 Black physicians. So what does that mean? Those 25,000 to 35,000 Black physicians could have provided culturally responsive care to hundreds of thousands of Black patients. We could have had research more focused on the health of our communities. These physicians could have mentored multiple generations of physicians and other health professionals. But instead, today, only 5.4% of all physicians are Black. And to get to this 5.4%, we literally have to jump through hoops. While my mother was this incredible physician, her own road was full of obstacles and barriers. Even before she made it to medical school, she was born into poverty in Brooklyn, New York. She grew up on public assistance. She was a descendant of enslaved Black Americans. She had never even seen a Black physician in real life. Once at her Catholic high school, my mother told one of the nuns that she had been thinking of trying for a medical degree. The sister laughed at her, despite her excellent grades. Maybe you could try for something else, the nun said. Can you believe that? Yeah, has it ever happened to anyone? Yeah, I know. Well, my mother was the first person in her family to attend college. She didn't have her first real mentor until then. It was her chemistry professor, Dr. Dillard, a Black man. He took a vested interest in her success. He encouraged her to apply to medical school, and guess what happened? She was accepted to all of her medical schools and chose Harvard Medical School. It wasn't an easy journey for her thank you, at all, but she eventually became a physician. So she went to medical school, and the rest is history. At 19 years old, my sister and I lost our mother to acute myelogenous leukemia. She was only 47, the age I am now, but her legacy continues. Oni and I both became physicians. We both attended Harvard Medical School, the school's first Black mother-daughter, thank you, legacy graduates. I became an ER physician. I chose emergency medicine because I thought that's the way I could help people most in need. As time went on, though, I came to view the ER as the place where our country's social problems come home to roost. People who don't have health insurance are more likely to use the ER for their care, and they are likely to be sicker. I wish I had known these things when I was a freshman in college. I didn't know what I didn't know. For example, I loved my neighborhood and my neighbors in Crown Heights, Brooklyn, where I grew up, but I knew that my neighborhood looked different than others. My parents still didn't feel comfortable sending us to the public schools there. We didn't have a supermarket. We always had to drive to another neighborhood in Brooklyn. We didn't have parks with lots of trees. I'd even seen several people get shot on my block. I knew some things, but I didn't know why. When I got older, I learned something that had stopped me in my tracks. The reason my neighborhood lacked basic resources wasn't just because of bad luck or poor planning. It was because we lived in a formerly redlined area, one of the many neighborhoods across the country shaped by discriminatory federal housing policies. And here's the thing, we know that today there's a straight line between those redline neighborhoods and the neighborhoods with the worst health outcomes today. So let's take a step back and look at the bigger picture. Americans are living shorter, less healthy lives than people in other high-income countries. That's not an opinion, that's data. And there's a big reason for that. Chronic diseases. These are long-lasting preventable conditions like heart disease, diabetes, hypertension, and certain cancers that we're seeing more of. In fact, chronic diseases have stalled our country's life expectancy over the past decade, while other high-income nations have continued to make gains. And it's not just our elders. Much of the gap is because working age adults are dying too soon. Let that sink in. People in the prime of their lives are dying from conditions that can be prevented or better managed. And then came COVID-19. As you know, the US was hit harder than many other high-income countries, even among younger adults who weren't supposed to be at risk. Why? Because too many Americans were already in poor health, already vulnerable. About 1 in 3 US adults has multiple chronic conditions, the highest rate among any high-income country. Diabetes is rising, and while people are living longer with it, we still have higher rates than we should. And yes, Americans move much less than many of our European counterparts. And then there's our fractured healthcare system. We spend more per person than any other country by far, but we don't guarantee healthcare for everyone. And we're more likely to skip care because of the cost. Fewer doctors, fewer nurses, fewer healthcare professionals, less access to basic preventive care. And let me be clear, we have some of the best specialists in the world here in this country. When you're really sick, if you can afford it, you're going to get cutting-edge treatment here. But when it comes to preventing illness, to keeping people well, we lag behind. And the gap between the wealthy and the poor is stark. Wealthier Americans live longer and are less likely to develop chronic conditions. Meanwhile, low-income Americans, especially in formerly redlined communities, face higher death rates and fewer opportunities to live long, healthy lives. And here's the kicker. Even the wealthiest Americans, they don't live as long as the most low-income citizens in countries like Norway or in the Netherlands. Think about that. To be honest, it took my own journey from child to student to practicing physician to discover the truth. And once I saw the truth, I couldn't unsee it. The truth is that I wrote my book Legacy for my younger self. It was the book that I wish I could have read when I was 18 years old. And to be honest, the reality of racial health inequities did not hit me truly hard until 5 years ago. I had to take action. One day in the early days of the pandemic, I was working in urgent care center in my hometown of Brooklyn. As you know, we were the epicenter of COVID pandemic in March of 2020. Within the first few weeks of the pandemic, something became very clear to me. All of my patients, they were getting browner and browner. I knew at the time the virus was going to devastate our communities. I knew because of the burden of chronic disease that our community members carry. I knew because of the fact that our community members were more likely to have public-facing jobs and were more likely to be put at risk. I knew because of lack of access to care. I remember on one 12-hour shift in urgent care, I was walking into what seemed like an endless number of exam rooms to find a young woman sitting there in her early 20s. The electronic chart said that she was there for shortness of breath. She was hunched over, staring at her hands when I walked into the room. She glanced up and gave me a once-over. I said, "Hi, I'm Dr. Blackstock. How can I help you today?" She said, "Can I ask you something? Are you Black?" I realized she couldn't see my full skin color under my mask, gown, hair bonnet, face shield. I even had shoe covers on. There was so much we didn't know about the virus, all that personal protective equipment. "Yes, I'm Black," I told her. I could sense the tension leaving her body. "Thank you, doctor. At least I know you'll listen to me." I promise. Can you see why our presence is so integral to providing quality care to our patients? Yes. I was so happy to be that physician she needed at that moment, but I also knew there was a larger issue at hand. I knew I needed to raise the alarm. I had to write about what I was seeing in my clinical practice. So I started writing op-eds. I wrote my first op-ed by the end of March of 2020. I became one of the first people in the pandemic to start writing about racial health inequities even before the data came out. I spoke truth to power and it created real change. Not only did I increase awareness, but my words informed legislators to make significant health policy decisions for our communities. I could have never imagined my life would take this direction. However tragic or chaotic this current moment feels, it is a pivotal opportunity for transformational change. Black patients and other patients of color deserve the best care, period. With all the work that I have done, there's one thing I want to be very clear about. Every single person deserves the right to be healthy. It's up to each of us to create change and recognize our role in improving the lives of everyone. The fact is, how long you live depends more on your zip code than your genetic code. Your zip code than your genetic code. My mother and her colleagues recognized this in the 80s, and they dedicated their lives' work. And although our mother wasn't there on my sister's graduation day from medical school, our self-appointed godmother was there. Her name is Miss Aileen. So let me tell you about Miss Aileen. She's from Alabama. She reminded me of my late grandmother. In fact, they were best friends. She was no nonsense, but doting with those in her care. She actually took care of my mother when my mother was sick, taking her to and from her chemotherapy appointments, cooking meals for her. Well, that day at our graduation, my sister Oni's name was called, immediately followed by mine. And as I walked across that stage, I heard someone yelling my mother's name. As you know, we get excited at graduations. But this was beyond a celebration. I heard her call, "Dale, your babies." It was Miss Aileen. I looked out into the audience and saw my family and friends on either side of her holding her up as she wept uncontrollably. I knew at that moment that Miss Aileen deeply understood. She understood the magnitude of what was happening in that moment. She understood the generations of struggle, the generations of perseverance and commitment to get my sister and me to that stage on that day. And that day, while I didn't know where my path would take me, I knew I needed to create a legacy for future generations, just like my mother had done. So more than 5 years ago, I began speaking the truth about racial health inequities. I didn't know where that journey would take me, but now I see it as my legacy. I documented what I saw, I shared it with the world, and now I'm able to work and do aligned work. This is my work, but it's not the only way. So where do we go from here? What can we do? Because this isn't just a crisis of policy, it's a crisis of will, and we all have a role to play. First, we have to stop treating health as something that begins in the clinic. Health begins where we live, work, love, and pray. It begins with the air we breathe, the food we eat, and whether or not we even feel safe walking outside. And that means investing in neighborhoods like my neighborhood, like that was historically excluded. It means funding schools, clean parks, public transportation, and access to affordable, healthy food. Second, we have to demand more from our healthcare system. We need care that is accessible, affordable, and proactive, not reactive. We should not be the richest country in the world where people skip doctor's visits because they can't afford them. And third, we need to change the way we think about prevention. We wait until people are sick, then throw everything we've got at them. But what if we made it easier for people to be healthy in the first place? That means supporting policies that improve the quality of people's lives, not just with advice, but with infrastructure that makes these things possible. And finally, we have to tell the truth even when it's uncomfortable. We can't fix what we won't face. So let's face it together with urgency, with compassion, and with a commitment to build something better. Because every policy is a health policy. That's how I see it. And every one of us, whether you are a community organizer, a health professional, a neighbor, or policymaker, has the power to move us forward, not just toward longer lives, but toward lives that are healthier, fairer, and more whole. What will be your legacy? Thank you.
All right, thank you all. We got some good holdouts for the rest of the remainder of the conference. We appreciate it. I know we have other breakout sessions that are also ending right now as well, but I'm going to go ahead and close this out because I want to, again, make sure that we're giving back time to people as much as possible. And just to thank you again for your participation today. I really hope that you all had a great experience during our summit this year. Please join me in giving just one more round of applause to all of the speakers that we've had today. Now, as we close out our time for this summit, I did want to extend my deepest gratitude to each of you for your presence and engagement throughout the day. Together, we explored many critical issues related to chronic diseases in Black communities, and we focused on identifying the problem areas, but more importantly, the solutions that are needed to address access and affordability with regards to management and prevention. Now, as we move forward together, the discussions and ideas generated at this summit must translate into action. This was something that our president and CEO, Nicole, said at the beginning. We want to close with that same thing. We need to take action steps to engage moving forward. So let each one of us commit to building upon the momentum that we have generated here, because it's really only through this sustained advocacy, the strategic partnerships that we have, and our own unwavering dedication that we will overcome the challenges that are before us. Now, before I close, I want to offer my most sincere thanks to all of our sponsors that on behalf of the Congressional Black Caucus Foundation. So thank you to Johnson & Johnson, our title sponsor, to Genentech and the United Health Group, to Bridge Bio and Pharma, and to Harmony Biosciences. So thank you to all of our sponsors. We truly, truly appreciate not only the financial support, which is really important, but also the substantive and topical support and the ongoing efforts of each of these organizations in terms of advancing equity for underserved communities. Thank you all as well to all of the organizations that joined us for our health fair. I hope that each of you had an opportunity to engage with all of the vendors and tablers and to get connected with the various resources that they represented and all the different community organizations that we are seeing that are out here doing really great work. I'd also ask that you join me in one last round of applause for the incredible team at the Congressional Black Caucus Foundation. Thank you. I am incredibly honored to be doing this work with each of you and in support of improving the lives of Black people and everybody else by extension. Now, in closing, before you all get out of here, I just have two really quick requests for everybody. First, please join us this September for our annual legislative conference. It'll be taking place September 24th through 28th at the Walter E. Washington Convention Center in downtown DC. Make sure you save those dates and be on the lookout for registration. That will be coming soon. Make sure then you also, secondly, stay in the know about what's going on at CBCF by following us on X, on Instagram, connecting with us on LinkedIn, and on Facebook. So thank you all once again for your time, and on behalf of the Congressional Black Caucus Foundation, I wish you all a great remainder of your day. So please go forth in peace and in purpose. Thank you.